hosted by our CEO, Collette Thain, and we're delighted to be joined today by Dr. Vinod Hegade. So I hope you have an enjoyable session, and I will see you later on.
Thanks, Alan.
Thanks a
Vinod,
lot.
are you well?
Thank you, bye.
Thanks. Are you well, Vinod?
I'm well, thank you, Collette. And I apologize for late.
No. We were to blame as well. We should have chased up and just checked. We just assume everything arrives, don't we?
Yeah.
All in the ether. I don't know what my granny would say about all this. Anyway, right, okay, first questions. What happens if you do not respond to either URSO or second-line treatments?
There are two parts to that question, actually.
Yeah.
What happens if you don't respond to URSO? Let's start with that. If you're an URSO non-responder, or if your liver biochemistry has not responded satisfactorily after taking URSO for a year, we know very, very well from evidence that you are at a higher risk of disease progression. You are at a high risk of PBC getting worse and development of scarring or cirrhosis in the years to come. So not responding to URSO is bad news. But good news is that there are medications available for people who have not responded to URSO. So that brings you to the second part of the questions. If you haven't responded to second-line therapy, which is obeticholic acid, then at the moment, you don't have any other medical options, but there is an option for you to take part into clinical trials. But I must reassure you that 70% of patients with PBC respond to URSO, and those 30% of people who do not respond to URSO get started on obeticholic acid. And majority of the patients who take obeticholic acid do respond, so their biochemistry or liver blood tests improve. But if you don't, then we will continue URSO deoxycholic acid, and we may continue obeticholic acid. But if you want to stop the obeticholic acid, you can after discussing with your consultant. But you have access to research trials or clinical trials to try some other drug.
Thank you, Vinod. That's quite interesting. Can I add to this? And if you wouldn't mind commenting. So when I was diagnosed with PBC 110 years ago, there was no URSO and there was certainly no OCA. And then, I think it was licensed in 96, 97, round about then, I can't remember. And it was a very slow rollout. It's fine if you're in the big units, but very, very slow. And we were gathering speed with our membership. We had lots of people on board in their 80s and 90s. And our oldest was 103, and they'd never had any access to URSO. So is it fair to say that not everybody will go channeling towards a liver transplant, and that some people will die with it and not of it, despite being not responders?
Yes, no, absolutely. Collette is absolutely right. Majority of the patients, even non-responders to URSO, PBC is a very long chronic disease. It is very rarely, and a very small number of patients, it's a rapidly progressive disease. But in majority of the patients, it's a very slow, benign course. So most patients die with PBC than of PBC. Collette is absolutely right. And the role of transplantation is there, but again, less than 5% of PBC patients develop an indication for transplant. So that should be the very reassuring thing for majority of the PBC patients.
Yeah, because it is scary, isn't it?
It is.
That's great, thank you. So the next question, there's two questions. It's in two parts from the same person. They're very, very good questions. Would progression and severity of PBC cause an increase in blood platelets in a middle-aged female? Platelets have increased from 286 to 346 in the last 4 months.
The simple answer is no. You would expect the reverse, actually. If the PBC is progressing and if one is developing cirrhosis, you would expect the platelet count to drop, not rise. So falling platelet count is a marker of cirrhosis. Any cirrhosis for that matter, alcohol, fatty liver disease, doesn't have to be PBC. So we do not expect the platelet counts to go up if your PBC is getting worse. The opposite should happen. If your PBC is getting worse, you should be developing thrombocytopenia, which is drop in your platelet count. So if your platelet count is rising, and I don't think it's rising, that concerningly, but worth getting checked with your GP and going to a hematologist or a specialist in blood.
Well, this belts into the next question. Is that if there has been a recent increase in blood platelets, is it advisable to have the COVID booster vaccine and the flu jab?
I am not aware of any evidence to say that the booster is contraindicated in somebody with a rising platelet count. And we are not routinely checking anybody's blood before giving a booster. So the answer is you should get booster irrespective of your platelet count.
Okay.
Booster doses of COVID are safe, and there are hardly any contraindications for it. So I wouldn't stop you from getting your booster just because your platelet count is high.
Yeah, and the booster, it's only a small dose compared to what the actual
Yes,
vaccine
exactly.
was, isn't it?
Yeah. It's unlikely to affect your platelet count.
Yeah, okay. I've recently been diagnosed with PBC and I've started on Urso. I'm currently suffering with pain in my legs, especially at night. I'm not sure if this is related to PBC. However, the doctors prescribed me amitriptyline and I'm unsure about taking it as I don't want to have an adverse effect on my liver. So it's kind of two questions in there again, isn't it?
It's a very good question. It just shows you that PBC patients develop many other symptoms which are not directly related to PBC.
Yeah.
And this is a classical example. Can I assure you that amitriptyline is safe in PBC? I give it to my PBC patients if they have indications for amitriptyline. Yes, amitriptyline has got its side effects of sedation, constipation, dryness of eyes, and all that. But if you take the correct dose prescribed and take it in a smaller dose and take it gradually and increase the dose gradually, those side effects are usually tolerable. Amitriptyline does not make your PBC worse. So if your doctor has given it, you can try it.
What about suffering with pain in the legs at night? I mean, that's a difficult one, isn't it?
People get sometimes restless legs. Restless legs are very common in PBC. I don't know this person's age group.
No.
It's more common in elderly women with PBC. But amitriptyline is worth trying. It's as I said, it's safe. It doesn't work, then you can always go back and ask for something different.
I would also add on to that, if I may, that she's asking about, I don't know whether to take adverse effects on my liver. The pharmacists, the chemists, these people come highly qualified, don't they? And they're very, very good about telling you what you mustn't take with what and what dose and what distance apart and all the rest of it. Yes. So never hesitate to. I know Boots and various chemists, you can have an appointment and sit and talk to somebody in private. But these people, they are highly qualified, aren't they, Vinod?
Absolutely. I mean, pharmacists in general, whether they're community pharmacists or hospital pharmacists, they are well qualified and they have far more knowledge than some of the doctors, to be honest. We in the hospital rely upon our liver pharmacists. We have a very low threshold to ask them about safety and advice. So please use that. Yeah.
That's a good point that you make. That's helpful to know, Vinod. When I turned up my booster vaccine yesterday, this person said, as I had a liver problem, I would get the third dose. I went along with that, with what they said. After reading when I get home, found this only for immune suppressant people, which I am not. Does this therefore mean I've had too much vaccine?
No, I don't think so. You've had your booster dose. There's nothing you can do about it. So I don't think you will come to any harm from this extra vaccine.
There's a good wee nugget in there. I mean, immune suppressed. Are people with PBC immune suppressed, or is it only late stage people with PBC who are immune suppressed? This is always one that I've never been sure about.
I don't think PBC patients are immunosuppressed. At least majority of the PBC patients who are in the early stage or in the middle stage of PBC, I don't think they are immunosuppressed. Okay. The technical definition of immunosuppressed patient is somebody with a lower immunity, either naturally lower immunity because they have a condition which suppresses their immunity, like a genetic condition, or if patients are on immunosuppression medications such as steroids, azathioprine, tacrolimus, those kind of medications which will suppress your immunity. And those patients are taking them either because they've had a liver transplant or a kidney transplant or some other kind of autoimmune condition they're on. Whereas, as you know very well, most PBC patients are not taking any immunosuppression medication. So technically, they are not immunosuppressed. In the later stages, of course, when you're cirrhotic, if you've got advanced PBC, if you're clinically jaundiced and you've suffered from consequences of cirrhosis, yes, then you are, you qualify to be called as immunosuppressed.
Okay, that's really helpful to know, actually.
Yeah.
Now, a bit of background info here that Alan supplied for us. On my bloods over the last few years, I've had a raised AFP, alpha fetoprotein, at 14 following further imaging, MRI, and repeat testing. It was decided in the absence of any problem that it was my liver regenerating. At that time, all my bloods were normal except the ALP, which was 268. All the other blood test ranges have always been normal. Okay, so the question is, however, the alpha fetoprotein has now increased to 19. Further MRI was clear of anything of concern, and the ultrasound shear wave elastography was deemed unremarkable. It's not a nice word, unremarkable, but anyway, comments, please.
Alpha fetoprotein on its own has got a very low diagnostic yield for a liver tumor. So alpha fetoprotein is a blood test that is used very commonly as a surveillance for liver cancer in a patient with cirrhosis. Again, any cirrhosis, alcohol, PBC, fatty liver disease, whatever. If you have developed cirrhosis, when you come to our clinic, we do your blood test, routine blood test, plus alpha fetoprotein. But we always combine the alpha fetoprotein with an additional diagnostic test like ultrasound scan or an MRI. So I would advise this patient not to read too much into the changing values of alpha fetoprotein. So a level going from 14 to 19 may not mean anything, because on its own, it has got a very poor sensitivity and a specificity for liver cancer. If your level jumps very high, they will do an ultrasound scan or an MRI scan to look for a liver tumor. But please do not read too much into the values on their own and don't get too alarmed.
There's another bit to this. My apologies. I thought it was a separate question, so I'll just give you a little bit more. If my alpha fetoprotein is now raised at 19, all my other bloods are in the normal range, including the alkaline phosphate 101. Should I still have such active liver regeneration? Is there anything I could be asking or for the testing I should consider? Is there anything that can affect the test result? I am a bit concerned. This all seems to indicate a high level of continuing injuries to the liver, but for it to be regenerating even with normal blood. So you're really saying it's not at all?
It's not at all, to be honest. Alpha fetoprotein goes up if you're pregnant. Placenta produces alpha fetoprotein, but the levels will be much, much higher. But in my routine practice, I don't dwell too much into alpha fetoprotein levels, as I said. If my patient has got cirrhosis, I do their ultrasound scan every 6 months. And there are centers in the world, renowned centers in hepatology, who do not test alpha fetoprotein at all because they don't believe in it. So depends which side of the pond you're on, the practice changes. So again, I'm saying, please do not read too much into alpha fetoprotein because you won't get all the answers that you're seeking, but you will only get reassurance from us that on its own, it is a useless test.
Right, that's actually very helpful because people do get a bit wound up and it's understandable. Right, I'm going to come to some questions on the screen, but Alan, Chris, whoever is there, I can only see 3. I've got Hilary and 2 from Jane Drydale. I have no facility to scroll down, so if there's any more after that, maybe Chris, you could do what you're actually doing with the other questions, please. So Hilary's saying, what is the ALP red marker after a year of or so?
So red marker as in something, I interpret that as at what level would I be worried?
Yeah.
So the normal level of alkaline phosphatase is 130 or below. So if your alkaline phosphatase is 130 or below, that is normal. But in PBC, it is very rarely below 130. So in most PBC patients, the alkaline phosphatase is above that upper limit of normal, which is 130. So a PBC patient may have an alk phos of 200, 300, 400. Some patients have very high levels of 800, 1000 I've seen. After a year of ursodeoxycholic acid, we expect the alkaline phosphatase to fall. So if your baseline alk phos was, say, 400, you take ursodeoxycholic acid for a year, we expect the level to come down. And ideally, it should be below 200. At this current time, in 2021, the thinking is, if your alk phos is below 200, you have responded to urso, and no further action is needed. You continue urso. If your alk phos is above 200 after a year of urso, you have incompletely responded or partially responded. So you need an additional medication. That's obeticholic acid.
Good. Okay, Jane, is this hereditary to my son or daughter? Please, no.
No, it's not hereditary. This question keeps coming, and it's a very common question, and understandably a very worrying question for a parent of PBC. Reassuring thing is PBC is not hereditary. This is not something that you can pass on to your offsprings, son or a daughter, through your genetic links. It doesn't have a classical Mendelian type of hereditary passage. Just because parents are diagnosed with PBC doesn't mean that their son or daughter will get it. No. But if you look at the epidemiology of this, there is a relative risk to your son or daughter, which is extremely difficult to quantify. Even a geneticist will not be able to give you a true quantification of what is the risk of your son to get a PBC. So we do not recommend a patient's son or a daughter to be screened for PBC. At least, not until they become adults. If your son is only 10-year-old, please don't worry about them getting PBC. Wait till they're 18, and then you can have a chat with them. And if they understand the implications of testing, they can go and have a blood test for anti-mitochondrial antibody and whatnot. But by and large, you do not have to worry about your children or your siblings because it's not hereditary.
No, and quite often what happens, I'm one of 7 children, I'm the only one with PBC, being nicer than the other 6, you understand. Only nice people get PBC, but quite often you find is in the family, cousins and uncles and aunts, there's other autoimmune conditions, there's thyroid or this or that. You quite often find that there's sort of more autoimmune conditions around the family, none in particular order. Jane's also saying non-alcoholic drinks, obviously sugar loaded is a limit on this. I don't have cirrhosis and alcohol. Well, there would be a limit for your health anyway, regardless of PBC or not. Sugar is, to me, I think sugar is a toxin. I encourage people with PBC not to overload on sugar or refined carbohydrates. I don't know medically if you'd want to say anything about.
If you don't have cirrhosis and your alk phos is 122, you've got nothing to worry about from PBC point of view. Assume your bilirubin and albumin are fine as well. So if that is the case, then you've got nothing to worry. But as Collette says, sugar, high amount of sugar is bad, right? It alters the liver metabolism. It puts you at a higher risk of gaining weight and becoming overweight or obese. So overall, high sugar intake is bad for you. Now, I'm not aware of any upper limit where we have come up with a guidelines and you should not have so much above so much sugar. But in general, I would say follow a healthy lifestyle. We all like sweets every now and then. We all like a bit of Coke or Pepsi every now and then. But you should not go overboard. Look after your health in general.
Moderation. In all things. Okay, so this one's from a big hello from freezing Aberdeenshire. What are Vinod's views on taking HRT with a disease like PBC? I'm currently on both the aforementioned, which is HRT, estradiol, Linzetto, and Dutrogestan. But I feel the missing piece of the jigsaw puzzle for me is to add a tiny amount of testosterone in gel cream form as my blood test came back low.
HRT, by and large, is very safe in PBC. So we get asked this question a lot by the GPs, general practitioners, who write to us, my patient has got PBC, can I give her HRT because she has got menopausal symptoms? And we write to them, yes, go ahead. There are no studies to show HRT has got any adverse effect on PBC. So you can take it under medical supervision. So by and large, it is safe. But HRT is a drug, right? It contains estrogen, progesterone, and other hormones. There are reports of HRT causing liver injury, not just in PBC, but even in normal people. But that risk is very, very small. So if after starting HRT, if you're not feeling well, or if you're concerned, your GP can do a simple blood test to check if it has affected your liver. But in majority of the patients, HRT is absolutely safe and no monitoring is needed.
Yeah, and it can get you to a bit of a bad spell as well, and over a hurdle. And in the patch form, it seems to suit people with PBC quite well.
Yes.
Now, this is an interesting one. When you acquire more autoimmune conditions such as Crest syndrome as well as PBC, does that mean we're only going to get worse with the health? No. I feel my health is getting worse daily. Am I wrong in thinking that since health is getting worse, that transplants in the future, but with additional more autoimmune diseases, will they even consider doing mine? Before you answer that, I would just like to say to this person, you say, I feel my health is getting worse daily. Does that mean you're suffering more PBC symptoms? Because that is not indicative that your PBC is starting to progress at any particular speed. The symptoms of PBC do not correlate with where you are with your PBC in your journey, and they come and go. They can be there for days, weeks, months, and then go. And there's lots of things you can do to help yourself. So I'd very happily speak to this person in person. If they want to call in, you'll be put through to me. But over to you, Crest syndrome or other autoimmunes, does it affect them having a transplant?
No, you're absolutely spot on, Collette. Crest syndrome is associated with PBC, like any other autoimmune condition. But Crest and PBC do not make each other worse. There is no data to suggest that because you have developed Crest, your PBC is going to get worse. No, it doesn't go like that. Unfortunately, you will get more symptoms because you have Crest now. But as Collette said, those symptoms do not correlate with the disease progression of PBC. So your PBC may be absolutely fine, your bilirubin alphas may be absolutely fine, but you may get more and more symptoms from Crest. But that doesn't mean that you're going to need transplant or anything. That's not how we do it.
And back to what we said previously, my dear lovely cousin Maria, she has Crest syndrome, but she doesn't have PBC. And I would rather have PBC than what she's got. Anyway, that's just the way it goes at the moment.
Be careful what you wish for, Collette.
No, but she's much, much, much older than me, to be fair. Okay. Oh dear, I do get myself to hot water. Hi there, Vinod. I'm a non-responder to all medication available for PBC, and I have aggressive PBC. King's College in London advised me to do a trial as only option available to me at this point, which is really what you were saying earlier at the very start of the session, weren't you?
Yeah. So sorry, I missed a little bit of that. She has got aggressive form of PBC. She hasn't responded to obeticholic acid. Yeah.
She's been told she's a non-responder to all medication available for PBC. This could be the same person, of course. And she has aggressive PBC, and King's College in London advised me to do a trial as only option available to me at this point.
Yeah, unfortunately, that is right. We do have in Leeds in our clinic, we have some people, handful of PBC patients, unfortunately all young and less than 40-year-olds who have aggressive PBC, and they have not responded to ursodeoxycholic acid. We have given them obeticholic acid. They haven't responded, and they are a bit of a worry. At this moment in time, my frustration is I don't have anything else to offer them because there is nothing medically I can do for them as a tablet or a capsule. But we look after them very, very closely. We monitor them very, very closely. When I say closely, I mean 3 monthly monitoring for progression of their symptoms or liver tests. We do their blood test every 3 months with bilirubin, alphas, and we'll see how they are progressing. More drugs are coming. the good thing is more and more clinical trials are happening in PBC now than ever. Collette will tell you 15 years ago, nobody was interested in PBC, but now more and more are. So we need patients like you to please participate in the trials.
Yeah.
If your clinician has recommended a certain trial for you, of course it's voluntary, but please think about it, try to participate. Because if you don't participate, if we don't know which drug is going to work, we will never have a drug in
That's
5 years, right? So we need better drugs than obeticholic acid. Obeticholic has been a great groundbreaking drug in PBC, but it's not the be all and end all. We need more better drugs than that. And that's why we need trials. For trials, we need patients, we need participants. So we need people like you.
Which is wonderful. And I'm just so glad they're available, because can put yourself in my shoes. When I was first diagnosed when I was 37 years old and there was nothing, there was just a black wall facing me. And now there's so much hope and brightness. And the fact that you've got trials on that, it's wonderful, isn't it? You know, I'm really very pleased with this. So here we go again. I've got another cousin who's got celiac disease. Yeah. How common is celiac disease, gluten intolerance with PBC? I was told by George Mells, because he keeps pointing the finger at Robert and I, is celiac disease is particularly high numbers in Celtic type people like Robert and I.
Yes. I think, yeah. So the Northern European hemisphere has got higher proportion of celiac disease prevalence-wise. So it is not at all uncommon to have a PBC patient with celiac disease. I can't tell you exact percentage, but it is probably around 4 or 5%, I would think, that prevalence of celiac disease in PBC. I need to look it up. It's been a while since I did that, but I think the number is like something around that, 4 to 5%. So we don't actively seek celiac serology in every PBC patient, but if we have a clinical suspicion, we do run an autoimmune screen for these patients. So we check their thyroid profile, celiac profile, rheumatoid factors. As Collette said earlier, multiple other autoimmune conditions can coexist in a PBC patient. I think Gideon used to say he had one patient who had 7 autoimmune conditions. Ouch. One patient having 7 autoimmune conditions on top of PBC.
Wow.
So those things have been reported.
Yeah.
So it's not at all uncommon. So 2 or 3 autoimmune conditions can coexist. Yeah, celiac disease, hypothyroidism, and PBC. I think these are the very 3 common conditions. And things like Crest syndrome, rheumatoid arthritis, and other things can also coexist.
Yeah. So Hilary says, why is Ocaliva a second-line medication rather than first? Well,
very good question. Excellent good question. It can be a first-line treatment for somebody who has absolutely not tolerated urso. Again, genuinely intolerant patients to urso can have Ocaliva alone as a first line. So that's absolutely true. And I've got 1 or 2 patients who did not tolerate ursodeoxycholic acid at all. They had terrible diarrhea, terrible GI disturbances, so we had to stop it. But their alkaline phosphatase was high, so we put them on Ocaliva. So technically, that second-line medication became a first line, if you know what I mean. But what you're asking is, why are we not giving Ocaliva right from the beginning of PBC diagnosis? No, we don't do that, because Ocaliva is a relatively newer drug, and ursodeoxycholic acid has been around for a longer time, and we have a much, much better long-term data and safety and all that. And urso is effective in 70% of patients. Okay, so, and it is cheap, it is safe, it is effective. So you should try that drug first as a first line before you go on to something like Ocaliva, which is more expensive, which has got side effects. And the way the Ocaliva was trialed was, it was never trialed as a first line therapy. So there is no study to compare Ocaliva against urso. Okay, Ocaliva was tried with urso in people who did not respond to urso, if you know what I mean. So if you want to have an answer to your question, somebody has to do a trial of, say, 500 PBC patients into 2 groups. One group only takes urso, and the other group only takes obeticholic acid. And they have a similar baseline parameter. and you do a trial for a year or two and see what happens, if you know what I mean.
But there is an ethical
That will
issue.
not be done.
Asking people not to take URSO as well as an ethical issue. But I would also say to you, Hilary, the URSO was licensed after its trials, and to get a license is pretty tough. And that was in 1996 or so. Ocaliva was licensed, what, 5 years ago, Vinod? 6 years ago?
2017, yeah.
All right, 17. So as the foundation, we're present with NICE, doing a patient presentation, so as they got a grasp of, what long-term PBC or non-responding PBC looked like, and they issued it very, very quickly. I must say, we were pretty impressed, Vinod. I think NICE do amazing work. So it's very recent, Hilary. It is okay.
Yeah.
So a lovely question here. And why do some of us get more autoimmune diseases? Wow.
Million dollar question. I wish I knew. I'm not an immunologist. Maybe you should ask this question to Professor Jones when he comes on these Q&As. He's a far better person to answer that. He's an immunologist, hepatology immunologist. Why do people get autoimmune disease? Well, why do people get cancer? Why do people get disease at all? Why aren't we all healthy? I think nobody can answer that question. It's something that is either genetically programmed or the environment that we live in that triggers something in our body. Maybe we're all born with something in our body that we don't know, and depending upon which part of the world you are growing, that it has got influence on your immunology or immunity or genetics, whatever. It triggers something, and then you develop it, right? So it is. I know it's a very vague answer, but that's in a way true, because nobody knows why somebody gets autoimmune diseases. But it is true that certain diseases are common in certain parts of the world. So, and not every country has the same number of patients with a particular condition. For example, colon cancer. Colon cancer is much, much higher in Western population, much, much lower in Asian countries. Whereas there are lots of diseases in Asian countries which are far more common than UK or America. So I think the environment plays a role.
It's multifactorial, isn't it?
It's multifactorial, and it's not something I always tell my PBC patients and other diseases. Well, it's you can't blame yourself for this. If you are blaming yourself for this, please don't, because it's probably just bad luck that you have this condition.
But equally, and I am very positive, having been around after all these years, my diagnosis, there are worse things to get than PBC. And we do have first line now, second line. So, we don't give up on this. We just keep buggering on, as Churchill would say. Sorry, my language is appalling today. It was Robert's birthday today. He's 50 today, by the way. I had a wee lunch with him. So now this is a good question. What dose of URSO should a person weighing 65 kilograms take? Now, I don't have the chart to hand.
I've got a calculator.
Have you got something there you can tell this person? We've got weight charts for everybody, Vinod, in metric and imperial weights. They are laminated. They are going to hit your doorstep. And the Falk Foundation are paying for these. You're all going to have them. Stick it on your fridge, because some of us have put a wee bit weight on with COVID. Some of us, not looking at anybody in particular, has just lost 3 stone. Some taking lesser. So, but do keep an eye on your weight, and we will answer your question. And don't wait on your doctor to check it. You do it and look at the chart and keep an eye on yourself. And if you have to go up or down, let your GP or your specialist know as well. Just drop them a wee email and just let them know. 65 kilograms.
So 65 kilograms is, you multiply that with 13, that gives you 845 milligrams. So that's the bare minimum dose of URSO you should be taking, 845. But it doesn't come like that. URSO comes in 250 milligrams, 300 milligrams, or 500 milligrams. So you need to round it off. So 65 times 15, if you do, it comes under 975 milligrams. So if you are taking around 900 milligrams of URSO, you are taking the correct dose. But if 300 milligram tablets or capsules are not available, and if your pharmacies can only give you in 250s or 500s, I would say please take 1000 milligrams or 1 gram of Urso. Slightly above your required dose, but it will not do any harm. Does that answer your question? That's how I do it with my patients anyway.
Yeah.
I round it off. I round it off to the closest zero so that the pharmacy can dispense it.
Yeah.
We've had a time, you may remember this, Collette, where 300 milligram capsules of Urso were not available.
Yeah.
You know, they were going out of stock.
The 500.
And only 250s and 500 were available.
That's right.
So check with your pharmacy, see what they have, the strength of the Urso. As I said, they come in 150s, 250s, 300, and 500. And using that, you can round it off to your closest zero.
Yeah, excellent. Right, I'm going to flip to, I want to talk about vaccines and boosters, if that's okay, please, Vinod. We don't have any more questions, which is great because we're doing good for time. I want to let you get way sharp. I know how busy you are. Before you come in, I was explaining how you hepatologists have been, well, initially you were redeployed into other parts of the hospital treating COVID, and every department, respiratory, kidneys, liver, everybody's got backlogs, and I know you're working really, really hard to catch up. And you probably know as well, Professor Jones has got COVID and he's not very well at the moment, and we're all kind of He's sending me messages, so he's a little bit cheeky, which is all right. That tells you he's not too bad. But and David is very lucky because he's like everybody else. He's had these vaccines, boosters. But we get lots of questions, and we hear lots of rubbish out there as well, and it's quite disconcerting. So I think we've done with the Bill Gates has put a chip in the vaccine. He's going to be watching us what we're doing and all this of it. I'm a bit disturbed about people not having the facts, about not feeling that it's safe. And I wonder if you might just talk a bit about the risks if you don't have the vaccine.
Yes. I have seen firsthand 3 weeks ago when I did a COVID ward cover from 18th of October for a week in my hospital. It was shocking to see a ward full of COVID patients, and 50% or more of those patients had not taken their vaccine. So first message is, if you have not been vaccinated, you have not only have a higher risk of getting the disease, COVID infection, but also higher risk of getting admitted to hospital with severe respiratory symptoms. So please, please, please take the vaccine. It is effective. It is safe. Nobody has put anything in it to track your activity, and it is the only way to reduce the transmission of the infection from one person to another person. And for you, what it means is it protects you from getting severe COVID and protects you from dying from it. Okay. Nobody, if you do get the COVID infection, despite booster or despite vaccination, evidence is clear that your risk of getting into hospital is lower. So you may get COVID, although you've been double jabbed, but you will not end up in a hospital, or you will not end up in intensive care. The chance of that is very slim. So it protects you from severe infection. It reduces your risk of dying from COVID. So I would encourage everybody, and I do that to my patients anyway, to receive the vaccine whenever you can.
That's very good. I mean, James says that sometimes his patients will ask him, should I take it? And he'll say, well, yes, but I'm happy to take you onto the ward to show you. And David Jones has said this is horrific to witness. Patients in hospital, he said it is extremely bad virus. So that's helpful. I've got another wee question in. Oh, bless you. As a non-responder to medication with cirrhosis, how long before it gets worse, do you think?
It's difficult to answer. Majority of the PBC patients with cirrhosis do very well.
Yeah.
Right. Even with what we call as compensated cirrhosis. Compensated cirrhosis means your bilirubin is normal, your albumin is not falling, and you are otherwise well. You have not developed any complications of cirrhosis such as ascites, which means fluid in your tummy. There's no swelling of the legs, no encephalopathy. You haven't bled from varices. So those are the markers of well-behaved cirrhosis. So patients with PBC, well-behaved cirrhosis, do quite well. They live normally for 10, 15 years. If you develop decompensation, which means you have developed one of the things that I've just mentioned, either jaundice, ascites, encephalopathy, bleeding, then your survival is reduced without transplant. And it's those group of patients whom we pick up and assess for transplant if they are fit for transplant. So to answer your questions, cirrhosis does not mean a death sentence. I always tell my patients, just because I've told you you have cirrhosis on PBC, it does not mean that you're going to die tomorrow. Okay? I reassure my patients that cirrhosis is not a death sentence. Majority of the cirrhosis patients do very well. They carry on as normal. You need to mitigate the other risk factors that can worsen your cirrhosis, and you need to have a very close follow-up with the clinicians every 6 months to monitor your liver blood test, scan, and everything. But,
and I think it's worth saying now, I hope everybody knows, and Vinod, I know you do, that there's a UK PBC audit that's being carried out in this country, which is just fantastic. It really is. And some figures are turning up in those audits, and those that are needing to visit transplant centres aren't always necessarily getting there continuously. So if you are suffering cirrhosis and you're not sure, if you're not attending a liver unit, and this is really important, please do contact me at the office, because don't let just let this go. It's maybe good that you're seen by one of the specialist centres, and they will oversee your care with your local hospital or however it may work. They'll work out a way of monitoring, looking after you, and this is really, really important. And don't be afraid to ask. Please, please don't, because doctors like you to ask. They like you to come forward. Gone are the days. Vinod's too young to remember those days. We've got one last question.
I'm fast approaching Robert's age, Collette.
He's always going to be ahead of you. Do you know when I was looking at him over lunch today, I thought, I can't believe it. I just can't believe it. I remember when he was just a baby. Never mind. This last question made me laugh. I had to send it back to Chris because I didn't understand it. That just tells you how old I am. So he sent it back. What do you think about CBD gummies? So I think CBD, is that...
It's cannabinoid, isn't it? Cannabinoid is, yeah, I think so.
And gummies, gummies are sweeties or something.
Yeah, I mean, this CBD oil, CBD gummies, CBD whatnot, it keeps coming up. All I say is, I'm not aware of any literature that has specifically looked at these things in PBC. So I won't recommend it. But at the same time, I don't have evidence to stop somebody from using it. Because these commercially available CBD oils or CBD products, I am told they have a very small amount of CBD in it, which is unlikely to affect liver. But I'm very skeptical about these things. I'm very cautious about these things because any product that you use which is not prescribed, you are carrying a risk of that product harming your liver. Okay? So if it is not given under medical supervision, you are taking that risk on your own. So please be careful. And if in doubt, don't take it. You got to ask why you're taking it, first of all. Why is it helping? Why is it benefiting you? What is it that you need to take it for? And if you're taking it, worry about the liver, and if you're taking it, get your liver checked, get your GP to do your blood test every now and then, because I've seen horrendous liver injuries from weird things that people take on internet. Okay, so weird kind of tablets, anabolic steroids, herbal supplements, dietary supplements. People take all kind of thing from internet because it is available now. Nobody's regulating these things. Things are available, and you would think, oh, I'll try that. I'll try that bit of this. but it carries a risk of potential liver injury. So as a liver specialist, that is my concern. And God forbid, if you take this, something happens to your liver and you end up in hospital with drug-induced liver injury, things can get pretty bad.
And we are in a time of COVID. Things are tight enough. Things are difficult
Oh,
enough.
yeah, absolutely.
So I think at some time in the past, Alan will certainly have a look for me after today. I think James did cover an article about cannabis and PBC some time ago, though. But we'll research that. We'll look that out.
Yes, I think it's worth updating because it keeps coming up in these meetings.
Yeah, I'm quite amused that I didn't know what it was, but hey ho, there we go. So Vinod, yet again, thank you so much. We're going to finish sharp. I've got to go into the office and do various things as well. But you know, Vinod, have a lovely Christmas with the family. Have you managed to get home to see your family?
No, I haven't been to India for 3 years now. So we might go next year. It's still a bit uncertain at the moment. So no, thanks. You guys have a lovely Christmas as well. For all
we will. Here's Alan to keep us right. Alan, you've got to find out stuff on cannabis for the good doctor.
Yeah, thank you very much, Vinod.
Fantastic. No, thanks, Alan. Once again, apologies for the delayed.
We will all in on that one. But this is such a great service. I'm sure people are happy. And thanks in the background. There's Chris there working all these buttons and controls.
Yeah, thanks very much to everybody. As usual, another brilliant session. So I'll close Facebook and everything down. So thanks very much, and we'll see you.
Everybody. See you next week. Dr. Alan Bonder from the States. Bye, Vino. All the best.
Thanks a lot. Cheers. Bye.
Bye.